Thank you everyone for joining. We are going to have everyone on mute until it's time for questions, at which point we'll unmute. So if you'd like to speak, just make sure that you are unmuted. And we wanted to thank you all so much for joining us today. Dr. Aaron Greenblatt will be presenting today. He is an assistant professor here at the University of Maryland in the Departments of Family and Community Medicine and Psychiatry, and he is also a Max consultant. So I will turn it over to him now. Thank you so much.
Hi, everyone. As Sarah was saying, this is Dr. Aaron Greenblatt, assistant professor here at University of Maryland, and I appreciate all of you joining us today. As Sarah mentioned, I would like this to be kind of participatory, like as close to a radio call-in show as possible. But I do have some information that I'd like to get through. If people would like to interrupt me and ask any questions, up at the top of the screen there is like a little speech bubble. That's a chat window, and I'm actually going to open up my chat window here as well. So if anyone wants to weigh in, ask questions, or stop me, object, please feel free to go ahead and do so. And I can get started here, as long as my computer will cooperate. So I don't have any financial disclosures. I'm going to be talking about, generally speaking, about buprenorphine in the primary care setting as used for opioid use disorder, but I'm going to take a couple of detours along the way into areas that are, I think, both useful and interesting, and try to build on some of the information that everyone has already seen at least once in their buprenorphine waiver training. There's plenty of information about how to use the medication in the waiver training, but actually there's some nuance to its use, and there's of course a number of clinical difficulties that can crop up for patients that are doing well or not doing well on their buprenorphine treatment for opioid use disorder, that I would like to try to address today. And I'm going to try to finish well before 1, so we have some opportunity to send in questions either by unmuting yourself when I've let you know that you're unmuted, or by sending in questions via the chat. So just to review, buprenorphine was actually first synthesized in the 60s. It was derived from one of the primary opioids or opiates that's present in the opium poppy. The main ones are morphine, papaverine, and thebaine. Thebaine itself doesn't really have any activity at the mu-opioid receptor, but with an alteration, it becomes actually a potent mu-opioid agonist. It was first marketed for pain by the early 70s, and then because of its pharmacologic characteristics, namely that it could be used sublingually, and that it had a very long half-life, in addition to a lot of receptor affinity, it was identified as a good candidate, in addition to methadone, for treatment of opioid use disorder. So by the mid-90s in Europe, it was being used, and by the early 2000s, thanks to the Data 2000 Act, it had been entered use in the United States for opioid use disorder. As you're all aware, I'm sure already, buprenorphine is available in a variety of strengths and dosage forms. Many, but not all of them, have naloxone in them. And the naloxone history is an interesting one, which I'll maybe save for later. Buprenorphine is also available in a transdermal patch and a buccal formulation that are approved for pain, not for addiction. But they may have some interesting uses for some of our patients. The reason that MAX exists, and the reason that that we're having this conversation today, is that there's actually a lot of doctors that have buprenorphine waivers, but unfortunately, many of them have never felt comfortable enough writing a prescription. It's difficult to imagine they haven't encountered a patient with opioid use disorder, but for whatever reason, there are some barriers to entry for using buprenorphine for the treatment of opioid use disorder. And even of those doctors who are writing prescriptions, a lot of them treat very few patients, like just a handful. So I want to spend a little bit of time talking about buprenorphine for pain. Not because I'm a pain expert. My colleagues up at Kernan Hospital here in University of Maryland are local pain specialists, but just do want to point out that buprenorphine, contrary to a lot of the lore that is available in the medical literature and also online, buprenorphine is actually a potent analgesic. And there's an excellent kind of commentary and review of this issue in this article that I'm posting here. It's a thoughtful and creative approach to this question about how clinically efficacious is buprenorphine for the treatment of pain. The references are all here. It's RAFFA, R-A-F-F-A 2014. And it cites here in figure 2 that I have on the screen here. This is from another study, not original research, but it actually looked at post-op patients and compared sublingual buprenorphine, 0.4 milligrams, so significantly lower than the doses that are typically used for treatment of opioid use disorder, and IM morphine. And essentially, buprenorphine and morphine are 0.4 milligrams of sublingual buprenorphine and 10 milligrams of IM morphine are similar in their efficacy. In fact, at least for the first 2 or 3 hours, very difficult to distinguish clinically. So, and another study that I don't have here, but which is discussed in the RAFFA article, it shows that actually there is a ceiling effect, as we all kind of know from the training. There's a ceiling effect for respiratory depression, but comparing a lower and a higher dose of buprenorphine that's given in this other study shows that actually there doesn't seem to be a ceiling effect for analgesia for buprenorphine, at least not at clinically relevant doses. In animal models, the ceiling effect for analgesia seems to be at somewhere around 3 milligrams per kilogram. So that's a much, much greater dose, an order of magnitude greater than is used for treatment of opioid use disorder. So, the question is, we hear all the time, it's kind of drummed into us, buprenorphine is a partial agonist, but the point is that all opioids have a ceiling effect. A partial agonist is a drug that achieves less than 100% effect when 100% of the receptors are occupied. And that's true in vitro with buprenorphine, but in vivo seems to have a full agonist effect for pain in most studies that have looked at this in a kind of a systematic quantitative measurement way. There is, however, a ceiling effect for respiratory depression, which is why this medication is so safe and so useful. Just to bring this home, there's, again, no compelling evidence that there is a ceiling effect for analgesia, although there's lots of clinical lore. And in addition, actually, for patients that may end up in your office that have a complicated history with opioids, it's difficult to establish whether they have what we typically think of as severe opioid use disorder, but someone who's been receiving ever-escalating doses of opioid analgesics, who may be demonstrating some aberrant behaviors related to their prescriptions, like early refills or occasionally running out early, or calling for early, calling to let you know that they've lost their medications, or occasionally showing up positive for other non-prescribed opioid analgesics or other illicit drugs. These patients may have a significant component of opioid-induced hyperalgesia, which may be compounding or contributing to their opioid use. And it seems that it's possible that the very, very potent kappa antagonism of buprenorphine might actually be helpful for the opioid-induced hyperalgesia associated with chronic high-dose opioid agonist treatment. I'm going to continue here. So now that we've talked a little bit about pain, I'll return to this a little bit later, but I'm going to return to the topic at hand, which is use of buprenorphine for opioid use disorder. So we've all heard about twin epidemics of opioid addiction and overdose. Here in Baltimore, where I work, opioid use disorder is endemic. It's been transmitted across generations. It's been persistent. The rates of opioid dependence here are significantly higher than in other places. But other localities in Maryland, I'm sorry to say, seem to be catching up. And areas that were previously not touched seem to be increasingly embroiled in these twin epidemics. This was from the Maryland Department of Health, recently released report about deaths, opioid intoxication deaths, actually all overdose deaths in 2017. Sorry, in years prior, the 10 years prior leading up to 2017. And these, in the first 3 quarters of 2017 through September 1st, we getting pretty close to meeting 2016 numbers for opioid-related intoxication deaths. If we just look at the first 3 quarters of deaths, we've already beaten our 2016 record by 150 deaths. So this is just in one state alone, and in a state with already some access to treatment. So we have to do more. I can point out that actually these deaths, these opioid-related deaths, are really driven by an increase of fentanyl-related deaths. Believe it or not, in 2017, first 3 quarters of 2017, we had fewer heroin-related deaths than we did in similar time period in 2016. But deaths related to fentanyl have really skyrocketed. And fentanyl, as you all know, is a potent opioid agonist. It's being sold basically interchangeably with heroin. Many patients don't realize that they're getting heroin or getting fentanyl rather, or they only realize it when it's too late. And because it's so potent, it tends to, if it's not completely dispersed in the cut, as they say, or in the inactive ingredients, people get hit a little pocket with too much fentanyl and accidentally overdose. So once someone is overdosed, it's too late to diagnose them with, or had a fatal overdose. It's too late to diagnose them with opioid use disorder and treat them. I do want to just briefly review how you diagnose opioid use disorder according to the DSM-5. And basically, to review quickly, it essentially means that opioid use has gotten out of control for the patient, and that even though they or an objective observer would say that there is a major problem, they haven't been able to cut back or stop. Just to point out a couple ones here that I think are important for using buprenorphine in the primary care setting, that people are using opioids in larger amounts or over a longer period than was intended, that they've tried to cut back or they really want to cut back, but they haven't been able to, that they have craving, that they're spending a bunch of time trying to get opioids, that they're not fulfilling major role obligations, that they have physical problems that are exacerbated by their opioid use, what's this? That they're having interpersonal problems or engaging in risky behaviors because of their opioid use. Also, tolerance and withdrawal are characteristic of all drug dependence. These 2 criteria, number 10 and 11, can't be applied to patients who are receiving chronic opioid analgesics as a prescription, because we expect people will develop tolerance to withdrawal. But just to point out that many people who are receiving prescriptions for opioid analgesics from a doctor would still meet criteria for opioid use disorder. So these people, the complicated patients that just aren't doing well on their prescribed opioids, they could be diagnosed with opioid use disorder. For example, if someone has had an escalating dose of oxycodone, say, they thought they were going to just be on it after their surgery, and now it's 8 years later and they're still on a high dose of oxycodone. It's not helping. They'd like to cut back because of their constipation, which is a physical problem that's caused by the opioids, but they're unable to cut back. When they try to cut back, they feel withdrawal symptoms or their pain recurs. So even without using criteria 10 and 11, you can meet 2 or 3 criteria for opioid use disorder, which puts someone in the category of mild opioid use disorder. And so for patients that don't come in telling you that, hey, doc, I just want to stop using IV heroin, but hey, doc, how do I get off this oxycodone now that I'm on it? It may be that a significant portion of those patients actually do meet diagnostic criteria for opioid use disorder. Other than diagnostic criteria, the other way to diagnose opioid use disorder is when a patient comes in and says something to the effect of, help me, I'm just exhausted. I want to stop doing this. In Baltimore, people say, I'm tired. So once someone is told you or you've identified opioid use disorder, as Dr. Ingvild Olsen mentioned in her talk, which is archived on the MAC's website, there are a few different levels of care that people can pursue to try to help them with their substance use disorder. And this applies not only for, most of these apply not only to opioid use disorder, but to all addictions in general. Basic idea is that people can try to go it alone. So sometimes in the 12-step programs, they call this white knuckling it, or going cold turkey, which essentially means just quitting without any kind of medical support or social support. People can participate in 12-step groups like AA or NA or Celebrate Recovery or the Life Ring, or there's a more, I'm blanking on the name of it right now, there's a more secular version called Smart Recovery. So there are a variety of self-help groups. A little bit difficult to study in part because the AA and NA have always been disinclined to participate in randomized controlled trials, but there are some studies that suggest that people who participate in 12-step groups will do better in treatment. Of course, you have to take those results with a grain of salt because of the selection bias that's inherent in those results, but it's certainly true that a patient who participates is more likely to do better. Just as patients who, according to the principles of motivational interviewing, people who talk about change more are going to be more likely to implement change. And so participating in any self-help group is a way for people to talk about change, even if they're not fully at the action phase of the change continuum. Pharmacotherapy is an option for opioids and for some other substance use disorders. For buprenorphine, there essentially are two, or for opioid use disorder, there are essentially two contexts where people can get treatment. They can get treatment either in a methadone program, also known as an OTP, or the DEA calls them NTPs. Those are places governed by federal law requiring daily dosing or 6-day-a-week dosing, a certain level of counseling intervention, a certain level of structure. People can get methadone or now buprenorphine from the nursing staff daily under directly observed conditions from the nursing staff. And then buprenorphine filled the gap of office-based treatment when it was approved in 2003. So hopefully some of you who are watching this presentation will be participating, will be prescribing or are prescribing buprenorphine in your outpatient office setting. In addition to the pharmacotherapy piece, there is outpatient treatment that's essentially stratified into outpatient and intensive outpatient. So these are essentially insurance designations as well as designations in the ACM levels of care that outpatient is anything less than 9 hours of group and individual counseling a week, and intensive outpatient is 9 hours or more of group and individual outpatient counseling per week. Day hospitalization is at least 20 hours a week, and residential treatment or inpatient treatment is full-time. Sometimes supportive housing or halfway housing can be coupled with some of the outpatient modalities, so that some organizations are offering offering housing contingent on people participating in the required level of care, usually intensive outpatient treatment. It's just important to remember these levels of care, even when we're seeing our primary care outpatients, because just as it's important to know, we've all had the experience of taking a history, doing a careful physical for a patient, starting to come up with a plan, and then realizing, wait a second, this person needs to be in the emergency department. I can't be taking care of this person in my primary care office. Their oxygen saturation is 81%, and they have a distended jugular venous pulsations, and they have peripheral edema. They need IV diuretics. They can't be treated here in my outpatient office. So just as not every medical condition can be treated in the outpatient setting, so too can some patients are better served or kind of need to be served in a higher level of care. It's a reminder about confidentiality. So there's a federal law called 42 CFR Part 2, which basically governs programs that have dedicated staff who are assigned to do addiction treatment. Program is covered by Part 2 if there are staff members whose only job is to do, or whose primary function is to do drug and alcohol treatment. This wouldn't apply to most primary care offices, but it does make it a little bit difficult to communicate with other levels of care. For example, outpatient programs, intensive outpatient programs, inpatient programs, or methadone programs, because actually, unlike HIPAA, providers can't communicate with each other without a written consent form from the patient, unlike HIPAA, which allows provider-to-provider communication for purposes of patient safety and coordination of care. Just something to remember. So, how do we treat opioid use disorder with buprenorphine and naloxone? I'm going to stop talking for just a moment and just give people a chance to take a look at that speech bubble on the top of their screen, right next to the button that allows you to escape from this experience that says leave. There's a little speech bubble that will open up a chat window. If there's any questions, please feel free to jump in and stop me or send me a message through the chat window. I'll be unmuting participants in a little bit to discuss some of the cases. So to treat opioid use disorder with buprenorphine naloxone, basically we get people started, we get people stabilized, so we get people on a regular dose, ensure that they're achieving the appropriate level of care, and then we continue, kind of like any other medication in primary care, whether it's metformin or hydrochlorothiazide. The point is that we need to make sure that we've titrated the medication appropriately, that people are receiving the appropriate adjunctive services, and that we're following up with them at clinically appropriate intervals, and using objective data to make sure that they're doing well in treatment. So I'm going to explore some of these, explore some of the challenges of outpatients by talking about some cases. Again, please feel free to send the chat message if there's any questions or if you'd like to participate in the cases. And I'll unmute people periodically at the end of each case to let people actually speak as well. So let's see, case number 1. First case, I'd like to talk about Mike. Mike's a guy that I've seen in my my addiction treatment office, but I could well have seen him in my primary care office as well. This is a 48-year-old man who's co-infected with HIV and hepatitis C. He's on treatment for his HIV, not yet treated for his hepatitis C. He comes in and diagnoses himself with opioid use disorder by saying, "I'm tired." So his history is that he's been sniffing heroin for the last 20 years. He's tried a couple of inpatient residential stays without medication. Those didn't stick. He relapsed shortly after his discharge from there. He was on methadone briefly in 2010, but he didn't like having to go down to the methadone clinic every day. And he's currently using 2 to 3 pills of heroin a day. Here in Baltimore, we measure in pills. Other localities, even close by, people measure it in different amounts. But he's spending somewhere between $20 and $30 a day on heroin. Also smokes a blunt a day and a half pack a day of Newports. Doesn't drink, doesn't use other drugs. Seems a little offended when I ask him if he does cocaine. No, I don't do cocaine. He loves fishing in the Inner Harbor. I made sure I let him know that he should not eat fish in the Inner Harbor, though. Rapid urine toxicology on the first day that I saw him was positive for fentanyl, positive for buprenorphine, positive for benzodiazepines, and positive for cannabis. Had some recent lab results back on him, and he had slightly elevated transaminases. Didn't seem like he was going to withdraw. So let me unmute. See if I can successfully unmute people. And if anyone wants to weigh in about this patient, feel free to unmute yourself as well and let me know what your thoughts are. I hear some people that are already unmuted that aren't participating, maybe some kids running around. If those people can mute their phones, that would be great. But if anyone wants to weigh in about what we should do about Mike, given his initial objective data and the report that he gave us about his current use. People are feeling shy or their mouths are full. So I can talk about Mike. We have a couple other cases we can discuss, and again, feel free to use the chat bubble if you prefer. I'm going to leave everyone unmuted for now so people can feel free to jump in as well. So I say, Mike, I didn't realize that you're taking buprenorphine. And tell me about the benzodiazepines. My understanding was that you said you weren't taking any other drugs. Mike says to me, "Oh yeah, I took a tiny piece of a Bude on Wednesday." Buprenorphine around here, but he's saying, I'm starting to feel a little sluggish, which is a word around here people use to describe, I guess, a feeling that you get with opioid withdrawal. Again, he's kind of angry or surprised at the idea that I'm asking him about sedatives like Xanax or Klonopin or Valium or Ativan. He says, "No, I don't take pills. It must be in the scramble. So it must be mixed up with the heroin that he's taking." So to start, Mike, he's feeling a little sluggish. He has some buprenorphine in his system already. Just a review, he's positive for fentanyl, buprenorphine, benzodiazepines, and marijuana. Interestingly, no opioids. I guess the first question is, Mike, when's the last time you used any heroin? And that of course affects things, because if he just used some heroin a couple hours earlier, even with a small amount of buprenorphine in his system, it would be a risky proposition to start his buprenorphine right away, because we could precipitate withdrawal. And we want to avoid making our patients feel significantly worse on their first day of treatment. We want them to feel better and come back and be retained in treatment. So Mike tells us, "No, I haven't used heroin in 2 days. I was feeling a little rough yesterday, so a friend gave me half of his buprenorphine strip, his Suboxone strip, and he hasn't used this morning." We ask him about his benzo use. He's never had a inpatient admission for related to benzodiazepine intoxication. He's never had benzodiazepine withdrawal. We check the PDMP, which is also known as CRISP, our prescriber's medication dispensing. What does PDMP stand for? The prescription records, statewide prescription records. And we see that he has not received a recent prescription for benzodiazepines. But we still have a couple questions. So we decided to call the Max line and get some opinions. I'm a little confused. He's positive for fentanyl. He's positive for buprenorphine. He's positive for benzos. I'm a little confused. So we call the Max Consultation service, which, as you all know, provides warm line consultation. It provides some continuing education, like the education that hopefully this is providing right now, and also can provide some resource and referral networking. And top of the list of questions that are appropriate are questions about how to initiate people and continue them on buprenorphine. So before we start Mike on his Suboxone, as we at Max would advise you to do, we'd come up with a clinic-specific treatment agreement. So basically an agreement about how the patient is going to receive his medication. We're going to make sure that he's appropriate for treatment in our office. So basically that would be for the clinic policy and for the clinical assessment. So something like the ASAM criteria. ASAM criteria can be cumbersome and costly, but really it's a matter of clinicians deciding on what they're comfortable with. Hopefully they're comfortable with a fairly high degree of acuity given the support that we can provide from Max. But you want to make sure that clinicians feel comfortable with the patients that they're that they're dealing with, or treating, I should say. That as part of the clinic-specific treatment agreement, we'll be establishing expectations regarding other drugs of abuse, including benzodiazepines, including alcohol, and as I already mentioned, checking the PDMP. There's a couple of different ways to start. let's say Mike says, yeah, I totally agree. I'm not going to drink any benzodiazepines. I'm not going to drink any alcohol. Once I stop doing heroin, I don't think you'll see any more benzodiazepines in my urine because I don't use benzodiazepines. Mike says he's already actually gotten in touch with an old sponsor from his NA days, and he's going to be participating in some self-help groups in addition to your treatment there. And you also have given him the number of a counselor that has some local counselor that might have some expertise not only in mental health issues but in some addiction. So from a practical standpoint, there's a couple ways to start buprenorphine. We can either do an observed induction, which is what the core of the buprenorphine waiver training talks about. So an in-office induction involves the patient going, either you having stock medication in your office or the patient picking up a prescription for buprenorphine and bringing it back to your office and taking it under direct observation. The advantage of an office induction is that it allows you to really titrate your dose maybe a little bit faster early in treatment. It also allows you to be sure that your patient is taking his medication correctly. And it ensures that you're able to really monitor the patient both in terms of symptoms and also in terms of clinical signs of withdrawal while you're starting those first few doses. From a practical standpoint, a lot of providers find that a home induction of buprenorphine naloxone or buprenorphine is more practical. And this is increasingly becoming the standard of care, or is increasingly becoming acceptable as part of the standard of care. And so, like with many things, communication with patients is key. First of all, as a practical standpoint, here in Maryland, medical assistants and most insurances will pay for 2 films or tablets per day of any dosage strength. So they'll pay for 2 2-milligram films of Suboxone, and they'll pay for 2 12-milligram films of Suboxone. They'll pay for 2 1.4-milligram tablets of Zubsolv. They'll pay for 2 8.6-milligram tablets of Zubsolv, or 11.4s. Similarly for Bunavail and for the generic medication, bizarrely enough, is not covered by Maryland medical assistants. So depending on what the patient's initial symptoms are and the patient's initial use, the typical initial first dose is somewhere between 4 milligrams and 8 milligrams. What I've typically been doing for my patients for home inductions is giving a patient an initial prescription for 2 4-milligram equivalent dosages per day. So that could be 2.8 milligram Zubsolv tablets or 2 4-milligram Suboxone films, which the patient could use at the time of treatment initiation. The most important instruction is to the patient for starting treatment is wait until you're feeling really, really bad. There's the COWS score, and you can have the patient fill out their own COWS. There's also the subjective opioid withdrawal scale, which the patient can fill out themselves. As you know from the training, you want them to have a COWS score that's high, at least 10 to 12 when they're starting themselves. And the whole idea is that the more wretched they feel when they're starting the medication, the better the effect of the medication will be, and the more likely they are to kind of come back and be retained in treatment. Kind of the worst thing that you can do for these patients is make them feel worse with their first dose of medication. The way to avoid that is by waiting as long as possible. Perplexingly, even though we think of fentanyl as a short-acting opioid, it seems that possibly because of some of the fentanyl analogs that are coming into the heroin supply or being identified in the heroin supply these days, it seems that we've been seeing some more precipitated withdrawal in people that are fentanyl positive than we would have expected from typical heroin positive patients. So I'm now recommending 24 hours of opioid abstinence, whereas from heroin alone, you could probably get away with 8 to 12 hours. But to be on the safe side, I recommend at least 24 hours of abstinence from full agonists, or until people are feeling really, really terrible. The first dose would then be 2 to 4 milligrams, or the equivalent of the buprenorphine naloxone sublingually. And then let the patient wait for another hour. If they're still feeling sick, they can take another dose. So consensus right now is that patients can take up to 8 to 12 milligrams of buprenorphine on the first day in divided doses. Remember that medications take 4 or 5 half-lives to reach steady state, and buprenorphine has greater than a 24-hour half-life. And the anticipatory guidance you can give to patients that relates to that is that even if they take the exact same dose for the first 5 days, each day the level of medication that's in their system is going to be building up. So we would expect that they would continue to feel better and better over the first few days. So I'm just going to... So some patients do well on lower doses. I have a lot of patients who are stable on doses between 2 and 12 milligrams a day. I don't think it's usually appropriate or necessary to prescribe 16 milligrams a day starting at day 1. In the case of Mike, I prescribed him, or I could have prescribed him 14 4-milligram films, or the equivalent in Zubsolv tablets, or Bunavail for the first week. Because of how busy my primary care office is, I could schedule up to a week after the initial visit. It's fine to schedule it sooner. It's probably better patient care to schedule it sooner, but it shouldn't be any later than a week after the initial clinic visit. Following up by phone, by text, by the electronic health record, these are all acceptable ways as long as they're HIPAA compliant. So we have the 1-week follow-up, and this is an opportunity to see how the patient is doing on their initial dose, collect a urine sample, not only to see if they've managed to stop doing their illicit opioid, but also to make sure that they're taking buprenorphine. And in the case of Mike, make sure that that his prediction about benzodiazepines has come true, that he's not actually using benzodiazepines regularly, because that does the additive effect with the respiratory depression from buprenorphine does give us a little bit of does make us worried a little bit about killing our patients. So possible wrinkle is that we're expecting to see Mike a week after our initial visit, and he calls 4 days later and says, Doc, I've been taking 3 strips a day. Actually, he probably says, I've been eating 3 strips a day and I'm all out of medicine. So when a patient says to me, I've been eating 3 strips, I kind of impulsively ask, are you eating them or are you using them sublingually? So Mike confirms actually that he's taking them sublingually. He's been taking 12 milligrams a day. He's all out of medication. And so what can you do about this? Practically speaking, we could talk about whether or not it would have made sense to follow up with Mike a little bit earlier. To schedule a follow-up appointment if your clinic schedule permits, 2 to 4 days after the initial home induction. But that could potentially help that a little bit. The other thing that we could talk about would be so from a practical perspective, we can, because medical assistants will approve for 2 of any dosage strength at any time. Actually, during that initial titration period, Mike says he's taking 12 milligrams a day. It's actually reasonable. It's a reasonable dose to have titrated to over the first 4 days of treatment. And again, that could be a question that if people had any doubts about that, they could check in with Max. But it would be fine to send in an additional prescription by phone to the patient's pharmacy for enough 12 milligram films to get the patient to his follow-up appointment with you that's already scheduled for a few days later. If that's, want to leave people an opportunity to ask any questions. If you unmute yourself, you should be able to be heard. No questions, it looks like, okay. Other questions. So how often should we be checking Mike's urine while he's coming into treatment? So that really depends on how well Mike is doing. At the beginning, it's reasonable to do it weekly to, again, ensure adherence, to make sure that he's been able to abstain from illicit opioids and to ensure that his urine continues to be negative for benzodiazepines. And then as patients are doing better and better, we can decrease the urine monitoring Typical practice is increasing the length of prescriptions to a month or so as patients are stabilized. There's a review by Dr. Fishman in 2011 that discusses typical outpatient management. Type of urine monitoring, so the presumptive or screening tests, which are done with ELISA testing or enzyme-linked immunoassays, that is a reasonable backbone for the drug screening approach. It looks like someone has asked a question. Would my approach change if the patient is homeless? Studies show that patients do well if they come in daily, but is that necessary? This is from Dr. Tyler. And I want to answer Dr. Tyler's question. So actually, I think that if a patient would benefit from additional psychosocial support that you can offer in your office, then that can absolutely be a useful thing to be able to offer. So, for example, I actually just had a conversation with the DEA, our regional DEA supervisor on Wednesday, who reminded me that actually private offices can dispense buprenorphine from stock as long as we want. We may even be able to get reimbursed for it for medical assistance. So if it would be useful, if it would be clinically useful for a patient to come in more frequently, absolutely bring them in more frequently. You can do that either by giving them a prescription for the, for the entirety of the time that you expect to see them, that will cover them until their next appointment, and just have them take it under observation with one of your clinic staff. You could dispense it from your clinic stock. The one thing that we can't legally do is hold a patient's medication for them, because that's their medication. It can't be out of their possession technically. These questions really end up being patient-centered. Some homeless patients it depends where they're staying, or if they're staying with a friend or family member where they could have safe storage of their medication, that could be useful. But if they're that could be fine for them to come in less frequently. If they're staying in an abandoned house or in a shelter where they can't ensure safe storage of their medication, a shorter prescription, more frequent monitoring would certainly be reasonable. Does that answer your question, Tyler? So just to remind, for patients that are not taking their medication under direct observation, in addition to doing the presumptive screens, there's a couple of ways to ensure that the patient is adherent, at least in part, to their Suboxone treatment. One way would be asking patients to do callbacks. So even if a patient has a 2-week prescription, you could call them as part of your clinic agreement. You could say, I have the ability to call you and ask you to come in to bring in your remaining medication. You could call patients kind of at random on day 7, say, hey, on day 8, could you come in and bring all of your remaining medications in, so I can just make sure that you're taking an appropriate number. That would be a reasonable way to make sure that patients are adherent to their medication. Another way to think about it would be to do urine confirmatory testing. So that's typically done through LCMS or GCMS testing, and basically looking for the presence of buprenorphine and norbuprenorphine in the urine, suggesting that a patient has actually ingested the buprenorphine, not just put a small piece into the urine. I'm just going to ask Tyler one more question. If Tyler can share with us information about the studies that show that homeless patients do best if they come in daily, I'd love to share that with the group as well. Again, also to remind people, especially those of you who joined late, that buprenorphine is available not just in office-based practices, but also is available through many narcotic treatment programs, methadone programs these days. If you think that your patient will benefit from the additional structure available in TPA, I certainly refer them there. I'm going to talk about another patient here, and somebody on the line here has their phone unmuted, and I'm happy for people to be unmuted if they want to ask questions, but if you're not participating, if you could make sure that your phone or your computer is muted, that would be great. Next case that I wanted to talk about would be Lili, who is a 31-year-old female who had exploded her disc, and as a result found a nice doctor to prescribe her 180 milligrams of oxycodone a day. But Lili found that she managed to she would manage to go through quite a bit more oxycodone than that. And then I'm gonna just pause Lili's question because I'm so grateful that people are participating. I see a question from Dr. Cadigan who asked, after the initial face-to-face visit, can the patient be seen by telemedicine? So this is a very interesting question, and I wish I could speak definitively on it. The Ryan-Haight Act, which I think Dr. Cadigan is probably quite familiar with, says that governs opioid prescribing of controlled substances over the internet and via telemedicine. I probably shouldn't comment definitively on how patients can be seen by telemedicine for prescription of controlled substances, but I will say that it's if you're confused about this, then you're not alone. My most recent report from the DEA agent was that actually the initial face-to-face requirement of the Ryan-Haight Act is actually related to internet prescribing, which this DEA agent, Agent Carter, actually differentiated from telemedicine prescribing, which is defined under the Ryan-Haight Act as well. So telemedicine prescribing actually doesn't even require, according to Agent Carter, does not require an initial face-to-face encounter, but it does require that the patient that you're seeing be seen either in a DEA registered clinic or in a clinic in the presence of a DEA registrant. So somebody that actually has the ability to prescribe controlled substances. Not buprenorphine, for not a Data 2000 waiver prescriber, but just someone who's a DEA registrant. And actually, as I learned just a couple of days ago, in the presence of doesn't even mean that that person has to be in the same room. They could be in the same building. So I think the brief answer to Dr. Cadigan's question, after the initial face-to-face visit, can the patient be seen by telemedicine? I think the answer is yes, but I think that the patient needs to be seen either in a DEA registered clinic or in the presence of a DEA registrant. And if this is a question that Max has some expertise on as well, so feel free to call in and we'd be happy to discuss this further. So to return to Lili, she had her exploded disc. She was taking more oxycodone. She had first started eating it and then started realizing that she'd get a faster effect if she chopped it up and sniffed it. She was tempted to dissolve it up and use one of her mom's insulin needles to inject it. But thankfully she sought some help, and after 2 months, she's able to remain abstinent from oxycodone on 16 milligrams a day of buprenorphine naloxone. And interestingly, she mentions that her pain has improved. At treatment initiation, she agreed to attend weekly appointments with an addiction counselor, but she keeps coming up positive for cannabis and cocaine on her urine toxicology. So she says, what are you going to do about it? Detox me? So any thoughts? Should we kick Lili out of treatment? No one has any thoughts. Well, I would address this issue in the same way that I would address any issue. First of all, I want to make sure that patient is still deriving benefit from her Suboxone. So we look at her urine toxicology. We've even done some confirmatory urine toxicology. Her buprenorphine and norbuprenorphine levels are appropriate. Actually, norbuprenorphine, the metabolite, tends to be higher than buprenorphine. So we think that she's taking her buprenorphine. She's actually been negative for oxycodone and illicit opiates. So it's working for her opioid use disorder. Interestingly, she's been following up with her addiction counselor and actually doing everything she wants to do in treatment. So the answer is, well, no, I think this seems to have been helping you with your oxycodone addiction and actually with your pain. But what do you want to do? What's your goal for your cocaine use? Is this working for you? What benefit are you getting out of cocaine? What are you finding useful about continuing to use cocaine? And And if Lili says, well, I actually really would like to put it aside, how can we help her do that? So one way to do it is by letting her know that if she was able to get abstinent from cocaine, she'd be able to get more control over her buprenorphine. She'd be able to have a longer prescription than weekly, or she'd be able to see her addiction counselor less frequently. And then also we could talk about levels of care. Well, maybe it would be useful for her to get some addiction counseling more frequently than just once a week. Just as a reminder, we always want to check the PDMP with our visits, and maybe it turns out that she's been seeing a nice ear, nose, and throat doctor who's been prescribing her cocaine. That's unlikely, but in the case of benzodiazepines, so we could have the exact same case. We could see that, in the meantime, Lili has started to see a well-intentioned psychiatrist who didn't check CRISP themselves and ended up prescribing high-dose benzodiazepines, not knowing that the patient was on Suboxone or a buprenorphine. Tyler asked another question. What if instead of ongoing cocaine use, it's alcohol? A bit more complicated. I agree, it is more complicated. Again, if the patient is abstinent from heroin, but using alcohol, again, the questions still kind of continue to be contingency management and thinking about how frequently you'd want to monitor the patient. I think what Tyler is gesturing at is the fact that patients who are drinking alcohol in addition to their Suboxone, we're worried that our medication is going to harm the patient in conjunction with their other substance use. And I feel like that would be the case for my alcoholic patients to whom I'm prescribing other medications as well. I'm worried that they're going to be not taking their medications correctly, that they're going to be forgetting, that they're going to have metabolic derangements from their alcoholism that could be interfering with their other medications. So I would again assess goals, remember some contingency management, and then alcohol actually does have some effective pharmacotherapies that we could consider with patients, including gabapentin, acamprosate, and even disulfiram. Obviously, naltrexone's out, but some of the other anticonvulsants could be of use. So we just have 3 minutes remaining in our hour. So rather than talk about the third case I had prepared, I think I will see if anyone has any other questions. Also, Tyler was kind enough to share this article by Dr. Alford, that's at Boston Medical Center, about treating homeless opioid dependent patients with buprenorphine in an office-based setting. And it seems that providing more clinical support to homeless patients with opioid use disorder is helpful for them. The conclusion of this article is that just because someone's homeless doesn't mean they can't receive office-based buprenorphine naloxone treatment. I'm going to skip forward a couple slides and thank you all for your attendance. Just a reminder that the max number is 855-337-6227. Save it to your cell phone. Please call us and use us. And just in conclusion, buprenorphine is safe. It's really satisfying to be able to treat deadly conditions quickly and effectively. And if you're getting stuck, please feel free to call our line and bounce your ideas or your questions off us, off my expert colleagues. And I appreciate your help and attendance today. Any other questions? Well, thank you very much. And if you feel like reliving this experience, this will be archived on the MACS website along with Dr. Olson's presentation from last month.